right. Okay, I think I got it. Yep. All right, good morning, ladies and gentlemen. Welcome to our third Breakfast with the Expert for this 2014-2015 academic year. Thank you for being here bright and early. It's my pleasure to introduce my friend, Mr. Sean McMurray. Mr. McMurray is the CEO of Johnston Memorial Hospital, where he's been for 12 years. He also serves, and I'm that's right, the CEO of Washington County, the entire county.
No, it's actually what we call our Northeast market, which includes Smith County, Washington County, and Russell County, and all the operations in those counties.
Okay. He serves as a fellow on the American College of Healthcare Executives. Really, more than anything, probably the most important thing is very happily married to Chris McMurray. Been married for 31 years. They have 8 children. So you thought 5 was something. That's nothing. And he's actively serving in church responsibility as well. So I'll go ahead and turn it over.
Okay, thank you very much, Colin. I feel very privileged to be here today. How many of you, I understand we've got a mix of graduate students and undergraduate students. How many of you are graduate students? Okay, so a good number of you. And this is your first semester in the program? How many of you have a background in healthcare? Okay, a couple of you. One of the trends that we've seen in recent years is more of the people who are going into healthcare administration actually come from clinical backgrounds. And that doesn't necessarily mean it's the only path. I didn't take that path. I actually graduated with an undergraduate degree in zoology and picked up classes in business and economics before I went to graduate school. So you can take lots of different paths to get where you want to go. But I want to share with you, when I was closer to your age and was looking at what I wanted to do in my career, I struggled a little bit to figure it out. Some people know early what they want to do, and I've got a couple of children who were that way. My wife was that way, but not me. So I actually spent a couple of years in Australia. It gave me lots of time to think. And when I returned to college, I decided I would take classes in different areas of study. And I'll never forget, I took an accounting class and really liked it, which is a little bit strange, maybe. And then I decided to take a second semester of accounting. It was a managerial accounting class, and I can still to this day remember the professor, Ray Garrison. He was amazing. And as I took that managerial accounting class, I decided I want to study business. I want to do something in the business world. So I continued to pursue that path. And along the way, a friend of mine who was a couple years older than me had been accepted to graduate school in healthcare administration. And so I started asking him questions. And I thought, this is a really great opportunity to do something in business, but also marry that with an opportunity to serve and do something that will make a difference to humanity. And that was kind of what drove me. So I ended up getting my graduate degree. I went to work for a company called HCA, Hospital Corporation of America, which is still around. At the time was the largest healthcare company in the world. They either owned or managed over 500 hospitals at the time. And so got my start there. Spent 9 years with them. Then went to work for a Catholic healthcare system, which was part of the Sisters of Charity of Nazareth, Kentucky, who eventually joined a conglomerate of other Catholic health systems and formed what was called Catholic Health Initiatives. And I loved that experience. It was an opportunity to really see firsthand what it's like to be in a mission-driven healthcare organization, and loved it. And then about 12 years ago, interviewed and got the job at Johnston Memorial Hospital, and that's been a really interesting ride too. Had the opportunity to sort of go through the whole planning process from the start. We were in a in a location downtown in Abingdon, if some of you have been there, where we were landlocked, didn't have any room to grow. We had an aging medical staff, aging facilities, and really had to make some decisions about what our future would look like. So we started with strategic planning, and that led to facilities planning. We ended up adding a cancer center, built a cancer center. We had acquired about 60 acres of land and knew that we would eventually want to expand the hospital and build a replacement for our older hospital. And we did that. We opened that up over 3 years ago and have continued to add services and grow. I think that's probably the key to any healthcare role that you fill. It's got to be something that you enjoy doing. It's got to be something that excites you. It's got to be something that motivates you to keep going, because the industry is a tough industry. I don't think I have to tell this class that there are some real challenges, and we're going to talk a little bit about some of those challenges today with my presentation. I would encourage you at this point in your careers, try to get all the experience that you can. Some of that is probably likely going to have to be volunteer experience. I wish you could get paid for it, but hospital budgets are pretty tight these days. And also I'd say this, hospitals are not the only place where you're going to go to work after you finish your degrees. There are lots of other options in the healthcare profession. So, but get as much experience as you can. Volunteer, shadow, if you can, with people who work in the industry in various aspects. I think that will make a difference and give you a better perspective, give you contacts as you start to look for jobs one day. The other thing I would say is there are lots of good jobs in administration out there. You can make a very nice living, but you're probably going to have to be mobile. As you move up the chain, you're going to have to be willing to move to perhaps other parts of the country. In our market, we have a robust healthcare system, but you'll find it surprisingly small as you get closer to the top. And so you have to be prepared, depending on what you want to do in the field, to be mobile. Any questions or comments about anything I've said so far? It's a shy group. Okay.
It was so sincere, that's all.
Okay, now you're going to have to direct the technology.
No, that's not the right.
Okay, gotcha. Okay. Let me tell you a story. I think one of the things that everybody's got to do as you look to the future and you want to find a place in healthcare is you're going to have to be really clever. You're going to have to be very smart about how you tackle things. You're going to have to be creative. I graduated from Brigham Young University many years ago, and one of the things that I was always impressed with, we had a president at one point named Rex Lee, and Rex Lee was an attorney by profession. He was a former Solicitor General of the United States. He's one of a few people who's argued at least 100 cases before the Supreme Court of the United States. Very, very impressive guy, but very down to earth. And he told a story once, I heard him share. He would buy his white shirts for work, and he would, after his first use, he would take them down to the local thrift store and donate them. And when asked why he did that, he said, well, he says, it would cost me, $1.50 to get my shirts pressed. When I take them down to the thrift store, I can go back in the next week and buy my same shirts back for $1. He says, not only that, they've done a great job pressing them, so they're already pressed, and I get to take them off as a tax donation. So anyway, that always impressed me about how clever Rex Lee was. And I think we're going to have to be that clever in healthcare to survive, because, and you'll hear me say this probably several times in this presentation, there is not enough money in the pot to pay for healthcare the way we provide it in the United States today. It just isn't possible. Wish makes me believe that we're going to have to significantly change the way we do business. All right? So I think you just need to know that going in as you start your careers in healthcare administration. And as you see my presentation here, Unsustainable Healthcare, please don't mistake that as me thinking that we're on a collision course with disaster. I'm still very excited to be part of this industry and to do what we do every day. It's a very noble profession and an opportunity to really make a difference in the world. But we've got to change if we're going to be successful. So, unsustainable healthcare. Let me share with you, can everybody see this okay? There'll be a few graphs that might be harder for the people in the back of the room to see, but you'll get the general trends. The size of the federal budget deficit is unsustainable. I can't even tell you how many trillions of dollars it increases every day, but it is huge. And I don't think anybody would disagree with the fact that if we don't change course as a country, we're going to be bankrupt. The annual increase in the Medicare budget is unsustainable. You know, a lot of this is driven by the aging of the population. We'll talk more about that. The percentage of healthcare spending to gross domestic product is unsustainable. As a country, the United States pays more as a percentage of its economy to healthcare than any developed country in the world. We'll talk more about that. State Medicaid programs are unsustainable. In fact, interestingly, neither Tennessee nor Virginia have passed health care expansion, Medicaid expansion, which is a huge expense for the Medicaid program. And frankly, everybody's worried about the growth in the Medicaid programs, and there's not enough money in very tight state budgets to pay for Medicaid. And then finally, the continued transfer of costs to employers and consumers is unsustainable. In the old days, hospitals would lose money on Medicare. We get paid below our total cost. We lose money on Medicaid. And of course, you guys probably already know that Medicare is the program that covers primarily the elderly. Medicaid is a combination state federally funded program in each state that covers the medically indigent, right? We would lose money on Medicare and Medicaid, but we would make it up on the commercially insured. All those companies out there that offer great insurance for their employees, we would just charge more to them, and we would make up the difference. Well, the reality is, in a global economy where people are really struggling to make a margin, it becomes impossible to just write a check for health care. They've got to look at that very big expense line and figure out how to reduce it. So that's impacted healthcare providers and our bottom lines over the years. So with that, I want to talk just a little bit more about each of those areas. Okay, this graphic represents the federal budget. And this is a projection. We don't know if it's exactly accurate, but it's the best we have these days. Starting back in 2010, the red line represents where the federal tax revenues come in. All right, so that's where everything that they collect, all the taxes, that's where we're at right now, where we're projected to remain. If you look at the dark blocks, these represent the major areas of expenditure within the federal budget. As you can see, when you add them up, they're already over that revenue line. So it means we're in a deficit, right? Now, the scary thing is, if you look at the major categories of expense, healthcare expenses are the one that are going up fastest. And so it is really problematic for our country as we're struggling with this debt issue that healthcare is driving us to the brink of bankruptcy. And you'll notice that as that line goes up, the interest on the debt continues to mount. And so it has put us in a very unsustainable position. We have essentially, if we don't change something significantly, we will mortgage our country's future. Okay, this one's a little hard to see. Don't worry about reading it, but Basically, this is a graphic from 1900 to 2050. This is a projected elderly population. The top line represents all those who are 65 years old or older. And the bottom line, which is rising quickly now, is those who are 85 years old or older. And again, what we're seeing is that about here is when the baby boomers have started to age out and become senior citizens. And that trend is going to continue for some time, and that is probably the one thing putting more pressure on the healthcare budgets of the U.S. than anything else. In fact, if I recall, please don't quote me on this, but when the Medicare program started back in the 1960s, I believe that there were 5 workers supporting every Medicare retiree. And it's projected that in the future that we're going to drop to close to 2 workers for every retiree. And so obviously that will put a tremendous burden on those of us who are still working. Actually, probably not me, but you. I think this was an interesting quote from the president back in early 2013 when we were really looking at it. You remember the fiscal cliff? And we were looking at some real significant budget problems in our country. The aging population and rising cost of health care makes Medicare the biggest contributor to our deficit. We've got to find ways to reform that program without hurting seniors who count on it to survive. That was both a challenge to the industry. Obviously, we want to continue to provide the needed services, but we've got to figure out how to do it more efficiently. But it also secondarily put a big target on health care. We are bad guys. When you look in the media, interestingly, 30 years ago, 9 out of every 10 mentions of health care in the media were positive. Today, it's reversed. 1 in 10 is positive. 9 out of 10 are negative. And this kind of thing doesn't help. Now, here I thought was an interesting statistic I found a couple of years ago. We talk about how much more expensive healthcare costs are in the United States versus other developed countries. But you'll notice here, if you look at a few of them, the United Kingdom, Germany, Sweden, and Spain, we spend a very similar amount per person up until about age 55. So as you're approaching Medicare age, our spending goes wild. What is it that we're doing or not doing at the end of life as we approach the end of life that's different from these other countries? I think we need to figure that out.
Do you have any, I've never seen that before. Do you have any insight on that, Sean? I mean, what?
Yeah, I do. My personal opinion, based on literature that I've read and other things, is that, among other things, how many of you in this room, you're a pretty young group, how many of you have advance directives in place? How many of you know what advance directives are? A few. Okay? Basically, they're legal documents that make your end-of-life wishes known. And then your medical providers have to provide care in harmony with your wishes. And most of it centers on not overutilizing care at the end of life. Well, at some level, these other countries ration care at the end of life. I mean, if you're in a socialized system like Canada, after a certain age, you're not going to get open heart surgery, or you're not going to get a hip replacement. So they have figured out a way to actually ration the amount of care you get. Well, what an advance directive is essentially a voluntary rationing of care. I personally have advance directives in place. I've appointed someone to be my representative if I'm no longer able to make my decisions. It's my wife, and she knows very clearly what my wishes are related to my end-of-life care. I do not want to have, on a long-term basis, a ventilator. I don't want to have other heroic life-saving measures to save my life. Part of that, after working in healthcare for nearly 30 years, is that I've watched a lot of folks suffer a lot at the end of life and not gain a lot of quality of life, even though we've spent tremendous amounts of money at the end of life. So I, at some level, I think we've got to come to grips with how much care we provide at the end of life. And that's a very sensitive, touchy kind of discussion to have. You know, on one side of the argument, you hear people who talk about death squads. But on the other end, I think it's a matter of us coming to peace with where we're at in terms of our life processes. You know, everybody's body is eventually going to wear out. Does that answer the question?
It does, thanks.
Now, another thing, this is where I mentioned earlier that we spend more money on healthcare than other developed countries. This one, and I apologize that the data is a little bit old, but there's fair delay in terms of gathering data from foreign countries. Here you can see a number of developed countries. This is how much we've spent since 1980 through 2008. But you can see the trend line. The top line, the black boxes, that represents the United States. And you can see that we spend not only more per person than other developed countries, and this is all adjusted for inflation, so you can compare apples to apples. But you see the gap between the other countries and the U.S. spending per person is increasing. That trend does not appear to have abated any as we move into 2014. Now, on the right-hand side, this one's, I think, very telling. This one is healthcare expenditures as a percentage of our gross domestic product, or basically, what percentage of the economy are you spending on healthcare? You'll notice here, as of 2008, we were about 16% of our economy was spent on healthcare. And most of the rest of the developed countries in the world were spending about 9%. Okay, significant difference. Today, last year, we spent about 18% of our economy on healthcare. Now, that's important because at the end of the day, every dollar we spend on healthcare is a dollar we can't spend on something that will help us to grow economically. It's a dollar we can't spend on education. It's a dollar we can't spend on infrastructure. It actually impedes the growth of our economy when we spend that much on healthcare. Anybody want to? Yeah, Dr. Weiss.
A question. I'm struck by the fact that there are periods of plateau and then rapid growth. So there's one in the early 2000s. Any analysis?
Yeah. In fact, this period in the 1990s was really the implementation of managed care. We started to see, for the first time, widespread utilization of mechanisms by health plans like primary care gatekeepers. You couldn't just go to a specialist. You had to go to a primary care physician and get a referral. Or narrow panels of physicians with better contracted rates, things like that. And it seemed to sort of help with the growth level in healthcare. Now, eventually, the pent-up demand exploded. We're entering another plateau because last several years, there have been so many discussions about healthcare being such a problem related to the deficit that we're scrambling like crazy to try to control costs. So I think it just runs in phases.
Does this take into account private insurers as well as public insurers? I mean,
this is all healthcare dollars.
This is all healthcare dollars.
Yeah. And just so you know, anybody know what percentage of healthcare dollars are spent on hospitalization? Yeah, at last number I saw was 31%. Anybody know how much we spend on physicians?
15 to 20%.
Right, 15 to 20%. And of that, primary care, we spend only about 5% of all of our healthcare dollars on primary care. But about 50% of healthcare expenditures are outside of what you would traditionally think is healthcare. It's not doctors, it's not hospitals, it's something else, okay? Whether it be nursing home care or whatever. Okay, now, another thing I'll note. Last year we were at about 18% of our economy was spent on healthcare. Anyone want to guess what we spent on the military? Because the military gets a lot of press about how much money we spend there. 14? No? How about this? Less than 5%. So we spend more than triple, almost quadruple what we spend on the military in healthcare. Now, some of you guys are all too young to appreciate this, but there was a President Eisenhower, who some of you may have heard of, and he talked when he had been obviously a famous general, and after the war became president. He warned about the military-industrial complex, that if the military ever took up too big a segment of our economy, that it would bring about the economic ruin of the country. Anybody know a real-life example where that actually occurred? Yeah, how about almost every communist country? Eventually, you can only pay yourself so much, and it only stimulates your economy so much when you're paying yourself to build up your military. Okay? So he said that back in the 1950s. Here we are 60 plus years later, and we're living it, only it's the healthcare industrial complex that is about to bring our country to economic ruin. So a real challenge. Also, here's another interesting fact. We spent 18% of our economy on healthcare. How much do you think China spent? 2%. It was around 4%. Okay? Now, where I live in Washington County, Virginia, let me share a real-life application of how that makes a difference. Bristol Compressors. I don't know if any of you ever heard of that company. 10 years ago, largest employer in Washington County, Virginia. 2,500 employees. Today, 500 or 600 workers. They have to sell their compressors, their products, internationally. So they compete head-to-head with companies from all over the world. Margins are very tight. How big a difference does 4% versus 18% make when it comes to that expenditure for healthcare benefits for your team members? It's huge. It makes us non-competitive in a global economy. Okay? Let me throw this in, and this is part of the reason we have trouble. You may have heard that, the healthcare industry, the rate of spending is down. We've been decreasing the rate of increase in healthcare spending. The problem is the delta is still a positive delta compared to general inflation in the economy. All right? So healthcare expenses, even though we've dropped them and they aren't increasing as much as we used to increase them each year, are still higher than general inflation. And as long as there's a difference there, we're going to keep growing as a percentage of our economy. Ultimately, the only way to fix this is to drive healthcare inflation significantly below what the inflation rate is for the general economy. That's what we've got to do to fix this. Here's an example. Classic Mustang. I don't know if you guys like cars, but this was a hot car when I was a kid. All right? Cost $4,500. Now, if you applied the healthcare inflation rate since 1970 to the cost of that car, it would be $133,000 today. Now, I like that car, but I'm not going to pay $133,000 for it. The reality is, an even better version today, $40,000. What that's telling you is healthcare inflation has been more than triple what the inflation in the automobile industry has been. And that's just one example of how out of kilter we've been. Now, part of that is not just that we keep increasing our charges and that people pay us those charges. Part of this is the fact that we have to spend more because people are utilizing more services as the population ages. So that's not going to change, and that's a real challenge for us as we move forward. Okay, we talked about how it wasn't sustainable to transfer the costs to employers for health care to make up the difference for the losses in our Medicare and Medicaid payments. Let me give you a couple of thoughts about some of the things the private sector is doing to fight back against high healthcare costs. How many of you are familiar with the concept of medical tourism? Any of you see shows in the last few years where people travel to India and they get their hip replaced. They send their loved one with them. They spend a few days at a lovely resort, and it costs half as much as it does in the United States, and then they fly them home. Okay? International tourism. And I remember a lot of people in the healthcare industry kind of said, that's never going to work. That really won't make a big dent. And it really hasn't to any large extent. Most people are not willing to travel across the world to get a hospital procedure done and have any risk of a bad outcome and then be in a foreign country. Okay? But it's now shifted to domestic healthcare tourism. Here are some examples. Some bigger companies that have a national footprint, like here, Pepsi, Boeing, that makes all the jets. What they've done is they've done their homework, and they've researched it, and they've determined that there are certain places in the country that provide exceptional care at a low price. And what they've done is they've incented their employees to use those facilities to the extent possible for some of these bigger ticket items. All right, an example would be Pepsi. If you go to Johns Hopkins to have heart surgery or your joint replacement, you don't have to pay out of pocket. Now, you don't have to go there, but if you don't, you probably have to pay 10% or 20%. Well, on a $30,000 bill, the average American is probably going to choose to go to Johns Hopkins. And so it redirects care to the place where they think it's going to be the most efficient and where they're going to get the best value. Boeing, same thing with Cleveland Clinic. They're known for their heart care, and they do that as well. So kind of a very subtle change in the industry. Here's a brief example. I'll call this a case study. There were 55 school districts in California who all used the same insurance company as their third-party administrator. And those people processed the claims, but then, like most bigger organizations, they were self-insured. Right? So they were spending so much money on healthcare that school districts who hire that third-party administrator, they say, you got to help us control our costs. So they looked more closely, and they realized that a small portion of the healthcare claims were responsible for the bulk of the expense. So they decided to do a little bit more research, and interestingly, they determined that of those big claims, 15% had the wrong diagnosis, and 60% of the treatments were not necessarily state-of-the-art. So they decided that they were going to do something about that. So working in harmony with these school districts, they redesigned their health plans. And the structure of a health plan is really important because it will provide the incentives for people to either use or not use healthcare services. Well, they redesigned their plan. They, if you'll recall, because they have these all these people who have health insurance that they process the claims for, that produces a big database of information. So they took that information and they divided out all the providers into 4 boxes based on quality and cost. Right? Now, what they did is they then put in place financial incentives for people to use the low-cost, high-quality providers. No premium increases year to year, no deductibles, no copays. If you use those providers, you got it all paid for. Now, you still have the choice to use other providers, with the exception of the low-quality, high-cost providers. They weren't going to reimburse anything for you to go to those folks. The others, you still had the option, but you had to pay out of pocket. And again, healthcare is expensive, and people are not going to do that. Do you think this had an impact on people's behavior, how they utilized healthcare services? Absolutely. 87% of the people who utilized healthcare services that were governed by this third-party administrator used the high-quality, low-cost providers. Okay? That has very significant implications for all of us in the future as we administer various healthcare organizations. Okay, now, I'm a little strange, but there is a book that's published on a regular basis that I love to look at. First of all, I love maps. Have ever since I was a kid. But this is called the Dartmouth Health Atlas. Any of you ever seen that? Okay, a few. Essentially, it's just page after page of maps of the United States, Each of these little sections is a county in the United States. And what they do is each map is based on a different health condition. And they look at prevalence. And even though they change the colors from map to map to sort of make it a little more interesting visually, the bottom line is, as the prevalence of a disease state increases, it becomes darker color. What do you notice about this map at first glance? Where is the highest prevalence of diabetes in the United States? The Deep South and Appalachia. And you know what? If you look through I don't want to spoil it if you want to read the book, but every map in the whole book looks almost identical to this. All right? Here's another one. Heart disease rates. Okay? Eerily similar to the diabetes map, right? Okay? So as we talk about healthcare expense and trying to wrestle with that, please understand there are lots of variables that impact it, and they're not all under the control of healthcare organizations, at least not directly, which makes our job even more challenging to try to rein in healthcare costs. In essence, if you want to boil down healthcare reform, it's really payment reform. Basically what it's done is the government has limited its exposure and shifted the risk to the providers of healthcare. We have to figure out how to provide the services we provide for less money and yet try to get better outcomes. That's where it's going to take a lot of creativity on our part. Now, before I move on, that may sound like a little bit of a slam on healthcare reform. The reality is, bottom line, again, what did I say at the beginning? There's not enough money in the pot to pay for healthcare the way we deliver it today in the United States. So we've got to change. And that's coming from the private sector as well as the public sector. Right? But same map. So we've got to figure out how do we help our population to be more healthy in their lifestyle choices. Here's an interesting one. This one is over time, basically over a 20-year period. Look back in 1990. You had the lighter colors around the country. If you look at the obesity rate, significant increases by 1999, and then in 2009, almost everything is pushed to the oranges and browns, and it's really significant impact on healthcare expense. And do we as healthcare providers directly impact the obesity level of people in the United States? No. But we know that their healthcare costs are more significant, and we've got to own that. We're now, in many cases, at risk for it. So it just presents additional challenges for us as we move forward. Now, here's another issue. We talk about healthcare in the U.S. being the very best in the world. And it's a little bit difficult to actually prove that in the statistics. If you line us up side by side with other developed countries, we rank near the bottom in almost every healthcare condition. And to boot, we're more expensive than all the rest. Just to give you an example, in Japan, they spend less than half, adjusted for inflation, they spend less than half what we spend per person for healthcare in the United States. But they have a life expectancy that's 5 years longer. And generally probably a better quality of life at the end of life than we have in the United States. So we do some things extraordinarily well. We've got the best technology. I'll share this with you. Early in my career, I had the opportunity to travel to Canada multiple times and do some research on the Canadian healthcare system. And I remember visiting Toronto a couple of times, and at the time, Toronto, the city of several million people, had 2 MRIs in the entire city. Johnston Memorial Hospital, where I work most days, has 2 MRIs. And I'm sure there are more MRIs in Toronto today than there were, 20 years ago. But nonetheless, I think that's one of the challenges. We've come to kind of expect the best technology. We've come to expect immediate care. And it's just not that way in every other country in the world. But interestingly, that doesn't seem to affect their outcomes, their health care status. So I think we have to ask ourselves some really tough questions as we move forward. Now, one of the interesting things is how safe is healthcare? I think it's interesting. I found this graphic. You notice that we're in the dangerous category where a serious incident is likely to happen greater than 1 in 1,000 times. We're ranked up there close to mountain climbing and bungee jumping in terms of safety. Now, on the other end of the spectrum, ultra safe, airlines. You know, I think that's interesting. What's the difference? Well, you know, one of the things that we do in the airline industry is they have determined what standard work is, what the best way to do the work is, and then they repeat it every time, and they do it the same way. In fact, they're so serious about it that whether it's the mechanics, work off checklists and regular preventive maintenance schedules, or it's the pilots who, when they enter that cabin of that plane, they're going over a checklist. And they got 2 of them there, a pilot and a co-pilot, just to make sure they follow that checklist. How many of you remember just a couple of years ago the 2 pilots that fell asleep over the Midwest and their jet drifted hundreds of miles off course? What happened to those pilots? Well, they eventually woke up. Okay? The plane did land safely. Okay? No one was harmed, but they fired those pilots. All right? They take it very seriously. Interestingly, I thought this was curious. In healthcare, only 30% of providers believe they make mistakes. Totally different mindset. We have got to work together in the future as teams. We've got to be humble and recognize that we don't have all the answers. We've got to work to try to establish standard work and then follow it every time, every day. All right? Now, here's an example. I just mentioned the healthcare industry. I love this one. Busiest airport in the world. How many of you have flown through Hartsfield International in Atlanta? Okay? Several of you. Right? 2,500 flights a day. 95 million passengers a year. Last 50 years, no fatalities. They've only even had 3 minor incidents. And that's how many millions and millions of flights. Okay? Now, by contrast, we report a lot of data to Medicare, to CMS, the Centers for Medicare and Medicaid Services. All hospitals across the country report on a number of measures that we call evidence-based care measures. And right now, the national average has been pushed up over the last 10 years, and we are now, as an industry, at close to 99% on many of those indicators. And, you know, we pat ourselves on the back about how much improvement we've made, how healthcare is getting safer. Well, think about it. 99%. If they had 99% success rate in Atlanta, there'd be 25 crashes a day. Would we accept that? Would we accept 1 crash a day at Atlanta? No. If there was 1 crash this year, it would get tremendous scrutiny. In healthcare, and granted, it's a little different. Every person's body is different, and it's not an exact science, all right? We do the best we can. There's still a lot of art to medicine, but we can do better. We can do more to approach the ultra-safe industries than what we do now. And I believe, personally, a large part of that is programs like Six Sigma and Lean, and really trying to look at our processes, simplify them, and make them better, and then follow them repeatedly. Okay, so that's kind of my thoughts about healthcare and the challenge that we face right now because of the money. What questions do you have that I will attempt to answer?
Okay, just a thought, comment, just for discussion. So we talk a lot in our country about people overutilizing healthcare services and overutilization as a major driver of healthcare costs. But there's actually increased now study and data showing that utilization of services is not the main driver of healthcare costs, but rather it is the unit price of healthcare services. So you mentioned Japan, for example, and studies comparing healthcare utilization per capita in the U.S. to Japan do not show that Americans overutilize services per capita compared to the Japanese. But again, it's the price per service, so it costs much more to see the doctor in our country. It costs much more to get a diagnostic test. It costs more to have a CT scan. It costs more to have surgery of any type. So it seems that our cost structure as a healthcare system is significantly higher than the cost structure of other comparable healthcare systems. So I just wanted to see, what your thoughts are about that, and if this is something that you've experienced or.
I absolutely agree with that. I hope everybody heard her comments. We're more expensive, and there's a number of reasons for that. I think part of it is, we've got a huge amount that we pay the middleman in the United States. Some of you may have followed in the media last year. Mountain States Health Alliance was in some very significant negotiations with Blue Cross Blue Shield of Tennessee. Right? Ultimately, they negotiated a rate that was significantly lower than what we had been paid on the prior contract. So they were driving our costs down, right? Okay, which should affect the unit cost for their insurers. Okay? They also reported that same year record profits of over $230 million. Okay? Many people who I talked to who had small or medium-sized businesses said that their rates were going up. At the same time, they were driving the per unit cost down through contracts with us. Okay? To me, I think that's a huge. There are not insurance companies. If you look at the biggies around the country, they make humongous profits. Remember one year, a few years ago, United Healthcare took it on the chin because their retiring CEO was retiring with $1.8 billion of mature stock options. Well, I can guarantee you, even though Dennis Vonderfeck did very well, he didn't come anywhere close to that kind of reimbursement. Insurance company executives are typically compensated extraordinarily well. So that's one of the drivers. That's my personal bias. If any of you work for insurance companies, I'd be happy to discuss that further and entertain your thoughts.
I'll face that way as I ask the question, because it's sort of here. One of the other challenges is that there still remains a sizable percent of our population that can't access health care, either because they don't have insurance or they live in rural areas. And probably if we took those populations out of the equation, our health outcomes would look about like other countries.
And the cost would be lower because we have to support that cost.
Well, that's actually where I was going to go with this question is how do systems like yours, which have a disproportionate number of people who don't have insurance, how are you going to fare if there's national changes in reimbursement rates and so on? It seems like you guys bear a larger portion of the uninsured market than other parts of the country.
We do. And I'll just share with you, in rural Southwest Virginia, and actually in the Tri-Cities, our Medicare rates are lower than the rest of the country. We have among the lowest payments in the whole country for Medicare. Part of that is because of the formula they use to calculate it. What they do is about half of your Medicare payment is determined by what's called the wage index. And essentially what that is an average for all the wages paid in your region. And they fix half your payment and attach that to your wage index. Well, what's the economy like in this region and what are wages like? You go to Knoxville or Richmond or, heaven forbid, Washington, D.C., and their Medicare payments may be twice what ours are. So, some real challenges there. We also have a higher percentage of uninsured. We have a higher percentage of folks on Medicaid in our region, and it makes it just more difficult. If you don't share this out of this room, I'll let you know that, perfect example, as a system, we count on Johnson City Medical Center, which provides a higher level of services to largely carry the economic water for the whole system. How the med center performs financially largely determines how the system will perform. To some degree, out at Johnston Memorial Hospital or Indian Path Medical Center, which are kind of our two secondary level medical centers where we do cancer service, higher level cancer services and heart services, we have to make up some of the deficits that we see at the smaller hospitals in the system. I can tell you, the other two hospitals I'm responsible for, Smith County and Russell County, don't cash flow positive. So we're already supporting the cost of indigent care in our communities. So it's a real challenge. So it's real. It is more per unit of service, but I think there's some things that have to be looked at. I think we have to look at another thing that is maybe unique about America is our malpractice environment. And the cost isn't necessarily in the value of the lawsuits, but it's the impact on how people think and practice medicine, how they order tests. They tend to be more conservative because they don't want to get sued. The reason being, if you just have 2 or 3 lawsuits in your career, it may be difficult for you as a physician to find a job. Whether there was any merit to those suits or not, whether they were settled out because it was cheaper to do that than to go to court, it doesn't matter. Usually you get 2 or 3 suits and you're probably having to make some career alteration. So that's a factor that drives up that unit cost of healthcare as well. There are a lot of factors. And again, I do believe that there are pockets of overutilization. Let me give you an example. Mountain States, as my employer, offers a high deductible health insurance plan, right? I have a $6,000 family deductible for the year, right? And I work in healthcare. Now, they give me back in a health savings account a couple $1,000s that helps to minimize that. My premiums are lower than they used to be because it's a less expensive plan to administer. But the reality is I, as a healthcare worker, have a high deductible health plan, right? Now, if you look at our utilization as a health system, as we've implemented high deductible health plans where we have more out of pocket that has to be borne by the insured, we've seen our utilization decrease. Right? So we know those incentives work, and we see it with other companies throughout the region. We've actually got, in this region of the country, the highest utilization of hospitalization in the whole country. I think the last time I looked, we were probably around 120, 130 hospital days per 1,000 population per year. If you go to California, I think that's 70 days. So we're almost twice as high as what the utilization would be in California. And I think it's largely related to we have a lot of people who suffer from chronic conditions like diabetes and high blood pressure, etc. We see lots of people with congestive heart failure and chronic obstructive pulmonary disease, you name it. We struggle with those, and those are the people who use the most healthcare services. So we've got to figure out how to prevent chronic disease, how to manage it better, more proactively, if we're going to be successful in driving down the cost of healthcare. But lots of different factors that affect healthcare utilization, the cost, and frankly, we are just lustful when it comes to technology in this country or the latest medication. What you wouldn't see in a foreign country with a socialized health program is they're going to have a very strict formulary that determines what medications you can get and have access to. Well, we don't always have that in the United States. I always think it interesting that people can buy drugs from our drug companies in the United States. We manufacture here, we send abroad, and they buy them more cheaply than we buy them in the United States. To me, that's unconscionable.
We're the only nation that does not negotiate, where the government does not negotiate prices with pharmaceutical companies.
There's other things. I don't know. Anybody here work for the VA? Okay, that's another interesting thing to me. We know the care at the VA is expensive. We know that they've been in the media a lot lately for long waits and other things. Well, the reality is, why do you even have a VA system? I think what we ought to do is provide the very best care for our veterans in all of the other hospitals around the country and bid that work out. Get the best price you can for it. And with very few exceptions, I think that would produce a equally satisfiable, maybe higher level of satisfaction for our veterans who deserve great care.
Like in other domains, right? Outsourcing has been a major driving force for reducing the cost of services.
Okay, can you repeat that? I couldn't hear.
In other domains other than healthcare, outsourcing has been one of the major driving force to reduce the cost of the services. So is that a possibility for healthcare also?
It is. We actually outsource a lot of services. If you look throughout my health system, we've outsourced dietary, we've outsourced in some of our hospitals security, we've outsourced housekeeping in some cases. We are starting to outsource a lot of stuff. Many health systems outsource all their billing and collections. So, yeah, it is a business strategy that we've adapted in healthcare. The only place where you have difficulty outsourcing is at the point of attack, where you're actually delivering care. Very difficult to outsource that. But even there, I'm contracting with a private group to run my ER. I'm contracting with a private group to run my hospitalist program. So, yes, even in the realms of clinical care, outsourcing is becoming a tool that we're using to try to run our business more efficiently.
I once read a number of years ago that the average rate of investment return in the U.S. on pharmaceuticals was 10,000%. Seems kind of high.
Yeah, that seems high to me too. But
I distinctly recall reading that. My other question, I'm sorry, that was just a point of fact, really. My question for you was, if you could snap your finger, I know no one can, but if you could, what would be the first thing that you would do? I mean, if you could make a change, knowing that we are over the mark from, if you can't spend $12 if you only make 10, that's just point blank. The buck has to stop there. So knowing that, when you look at that chart, you're like, oh, well, we'll work on this, but that's not really possible. You can't work on spending $12 with 10. There's nothing that you can do there. It's completely unachievable. You get what I'm saying?
Mm-hmm.
So, like, what's the immediate, the largest change for you that, I guess, one, that would be within your control, and two, as a health system that you would attempt to pursue from the state or national level, but just your within the local environment, and then also at the state and national.
That's a tough question. First thing, so I can think of several things I would do. Some of them easier than others. I talked earlier about our utilization of services at end of life being a real significant contributor to our utilization of healthcare services. One thing that would be, I think, relatively easy to monitor is you could require everyone, when they sign up for Medicare or Medicaid, to actually complete advanced directives and put them into a national database, so that if they receive care any place in the country, they could immediately draw that down and look at it and make sure that we're complying with people's end-of-life healthcare wishes. Right now, hospitals rely on the patients to bring those with them. We actually are required by some of our regulating bodies in healthcare to ask patients to bring their advanced directives, but no, they don't. We probably get about 10% of our patients who bring them in. So that would be one simple thing that could potentially start to change the culture in our country and the thought about end-of-life care. Another thing that's going on right now in the industry that could potentially hold promise is bundled payments. You guys familiar with that model? Okay. Mountain States as a system is participating in a bundled payment initiative at 3 of our hospitals, or 4 of our hospitals. JMH, we're doing it on total joint procedures. And essentially, you get a total bundled payment that's good for the entire episode of care, i.e. from their pre-admission testing through their surgery and then 90 days following. And you basically, for that payment, you own all the care of the patient. You have to pay the doctors. You have to pay the hospital. If they go to a rehab hospital, you have to pay them. You got to pay for outpatient rehab, for home health. It's all in one bundled payment. And what Medicare did was they essentially said, okay, if you're going to practice in this, or if you're going to participate in this program, here's how it works. We know what we've paid on claims for that diagnosis for your hospital for the last X years. Okay, we're going to give you 2% less than that. And we're going to let you be at risk, but if you can figure out how to do it better, you can keep the difference. All right? So the incentive is for us to figure out how to provide the care that we provide, and there are some safety mechanisms in place. For example, there are penalties for, and frankly, it just costs more if you end up with readmissions, if you get infections along the way, and you have to treat those. You kind of have incentives built in to provide the right care at the lowest cost. And there are only a few bundles out there right now that people are experimenting with. I know at Johnson City Medical Center we're doing open hearts as well as total joints. But the government has another 50 to roll out. Now the scary part is that some of them, the two I just described, open heart surgery and total joint surgery, are pretty defined, but there are things like chronic obstructive pulmonary disease that isn't, chronic conditions that they want to establish bundles for, and those people tend to have lots of readmissions and other things. Those are going to be a real challenge, but I think some of those payment models that are changing have the potential to help us start to change the culture and the way we think about care. I think plan design, here's the challenge we've got. When I look at private insurers, almost everybody I know, every major company has high deductible health plans, and they've got copays with incentives like, if you go to an urgent care, it costs you a $50 copay, but if you go to the ER, it's a $300 copay. So people, they think through it, and they go to the urgent care first to make sure that it's really not emergent, right? Okay, but we see no such mechanisms in traditional Medicare or Medicaid. Okay, so you got all the healthiest part of the population running around with incentives to try to use the system appropriately, and it seems to be working, but we've applied no such kinds of incentives on Medicaid or Medicare. I think that's another option. So I didn't answer your question with one, but there are a number of things. And frankly, healthcare didn't get this way overnight. It's a very complicated industry. Of course, that's one of the things I love the most about working in healthcare. No 2 days are alike. And that's been great for somebody like me who probably suffers from attention deficit disorder. Yes.
Thank you very much for your presentation. My question is on the aspect you talked about the aging population being one factors, the rise of healthcare costs. I was wondering what your perspective is, because this was said in 2016. I just wanted to know if anything has been done from that time till now, to see how it's been checkmate. And since American healthcare is more individualistic, less than universal, it's like healthcare measures are put in place for certain persons, like the Medicare, Medicaid CHIP program. Could you think this actually is one of the factors?
Good questions. First thing, has there been any progress made? We've started to bend the cost curve, but we still haven't driven it below what the general inflation rate is for the country. So lots of work to do, but there's been some progress. The healthcare industry is a little bit like a giant ship, and unfortunately, it is not easily turned. And so I think that's one of the challenges we face. Some of the things that we do today will have a positive impact, but it may be several years down the road. Here's an example. If we put more money into childhood education about good health and health habits, it's going to have a very positive impact, but it's going to be a generation before we start to see the beneficial outcomes. Another thing, when we talk about the cost of care, people don't just suddenly get sick when they're elderly. Disease processes have been going on for years in their body. When you start smoking when you're 20 or you're 18, you may not have serious adverse health consequences for many years, but I guarantee you, you will eventually have significant consequences that will impact the cost of care. Okay? On any given day in my hospital, probably 25% of the patients have diabetes, maybe even higher rate than that now. And probably close to 50% of them have been smokers for a significant period in their lives. So the decisions you guys have made and are making now in your lives are going to impact your health when you get to Medicare age.
Okay, wonderful. Well, we want to thank Mr. McMurray. Thank you. This was very helpful, very informative.
Oh, you're kind.
Lots of data, lots of examples from practice, and that's always my favorite kind of presentation. When I have the evidence, but I also have the practice perspective, that's the best merger that I can have. So thank you all. Thank you, Sean, for your time this morning. Thank you, Colin, for arranging this presentation. Thank you all for participating. Just a certificate of appreciation and a sign and a little gift to say thank you. And we will see you for the 4th Breakfast with the Expert, first Tuesday in December. And then also please keep in mind we have 2 special lectures that the college is sponsoring next week related to the Ebola epidemic. Okay, so those are special lectures at noon, which we will be holding at the Culp Center. So I hope that many of you can join us for those presentations next week. Thank you again, Sean.
Thank you for having me. And good luck to you guys. You're embarking on a career in a great field.
Thank you. Thank you very much.
Yeah.